The first thing I want to discuss is the prognostic stratification of patients with heart failure with preserved ejection fractions. To have the data, you need a big data set of subjects and you have to follow them up. You need clinical parameters, you need laboratory parameters, and maybe you can use some imaging parameters. Well, it is, but it is only recently that we got enough data, enough good data to make the point. So the first study to discuss is the iPreserve study. In the iPreserve study, they compared an RRB to conventional therapy in the setting of HFpEF in more than 4,000 patients. And when they looked at the prognostic stratification of this randomized controlled trial population, they found that NT-proBNP was by far the most powerful predictor of poor outcome. Other important parameters were the age, the presence of diabetes, and a previous hospitalization for heart failure. These were the main factors. Less important factors in that study were the quality of life, COPD, decreased renal function, inflammation, heart rate, let's say the usual suspects. But they were far less important than NT-proBNP, previous hospitalization, diabetes mellitus, and age. There is a sub-study on echo in about 600-700 subjects. And in this sub-study, they showed that left ventricular remodeling, especially the concentric remodeling and the increased LV mass and LA dilatation were independent prognostic factors. Then you ask the question, is an RCT the way to assess prognosis of my patient in clinical practice? The RCT is a very selective population, and the RCT is expected to be more restrictive toward women, elderly patients, and patients with many comorbidities. If you go to retrospective data, you will have more patients with established disease, and that's the reason we need population data. Very good population data were acquired by the University of Karolinska in Sweden and the University of Rennes in France, and this is the K for Karolinska Rennes study. This Rennes study looked at the general population and looked at the prevalence of heart failure with preserved ejection fraction. And in a way, they enrolled patients with many more comorbidities than patients in the RCT. And in that study, the independent, in the multivariate analysis, the independent parameters that were important for the prognosis were age again, history of non-cardiac syncope. Why is that? Well, this is a surrogate index of frailty. Valvular heart disease, anemia, lower sodium, higher potassium. This is a proxy for decreased renal function. But the remaining comorbidities were not important in the prognosis. So on this background, we can see what echo imaging can bring us more. The first study to mention is a study from the Mayo Clinic, from the Olmsted County Registry. There, the investigators looked at 1, pulmonary pressure, 2, right ventricular function, and they showed that right ventricular function measured, for instance, very simply with TAPSE, T-A-P-S-E, could add to the prognostic stratification, and this independently from pulmonary pressure. So we should have these data in every patient to complete his prognostic bilan. We cannot deal only with iPreserve without dealing with the more recent TOPCAT study. In the TOPCAT study, spironolactone was tested again, or eplerenone, I don't know exactly, one of the two, was tested against placebo in the same HFpEF population. And in this TOPCAT publication, they confirmed that LV hypertrophy is important and conveys an unfavorable prognosis. But they also showed elevated filling pressures evaluated by the septal E/E' ratio. The iPreserve investigators had tried it out with a lateral E/E' and were not successful. This could have been because of the fact that the septal E/E' is easier to record and more reproducible. Another parameter that came out quite significantly in this TOPCAT study was the tricuspid regurgitation velocity. Instead of estimating pulmonary pressure, it's much better to just measure the depth of the tricuspid regurgitation signal. This is more reliable and better as a prognostic indicator. In addition to these classical studies, I want to mention that we don't have to look exclusively at the heart, we also have to look at the arteries, because stiffening of the arteries can, independently from the disease of the heart itself, contribute to the prognosis of these patients. The best validated parameter of arterial function is the pulsed wave velocity. An emerging parameter is the reflection and the magnitude of the reflected waves. What is that? At each cardiac cycle, you eject 70 milliliter in the arterial tree. This creates a wave that goes till your femoral artery and then is reflected at many reflected sites to the heart. Normally, this contributes to increasing your diastolic pressures, your perfusion pressures. But if the wave travels fast and comes early back, and if the reflection is stronger, as happens with stiffening of the arteries, then it boosts your end-systolic pressure instead of your diastolic pressure. And it increases wall stress during the second half of systole. This late increase in wall stress and these reflected waves have been linked to diastolic function, diastolic dysfunction, to maladaptive hypertrophy, and to prognosis, because they are linked to incident heart failure, to all cardiovascular events, to all-cause mortality. So it's an emerging and new parameter that has been dealt with in heart failure with preserved ejection fraction. Well, I think that with the studies that we have so far and with the very specific analysis that were made in the last 2 years, we made a big step forward. And it's the first time that we attempted to bring all this information together in a sort of holistic approach of the problem. Can we still learn more? Presumably we can, because worldwide we are gathering data on, for instance, strain and strain rate imaging. And we still have to see to what extent these more sophisticated but more difficult to acquire measurement could give us more than what we have presently. Well, it's not a benefit for the cardiac surgeons, it's mainly a benefit for the general practitioners and for the clinically oriented cardiologist and the cardiologist specialized in heart failure. The biggest takeaway is that they shouldn't necessarily go to sophisticated indexes of myocardial function, but that they should just record simple things such as LV mass, left atrial volume, tricuspid regurgitation velocity, TAPSE, and you have it. and you have, let's say, 90% of what would be optimal. I think that we will still learn more about the interaction with the arteries, and I sincerely believe that strain imaging, especially the systolic strain, will give additional information about function and survival. There are challenges because, in a way, strain gives you a single number, but the number is achieved in a complex way, is dependent on the vendor, is dependent on the version of the software you have, and is dependent on the way you handle the data. So the reproducibility still has to improve.